We present a case of tuberculosis-induced bronchiectasis in a Hispanic male with CVID and cystic fibrosis carrier. Bronchiectasis is a chronic condition which is characterized by irreversibly dilated bronchi, which leads to debilitating respiratory syndrome with excessive sputum production and recurrent infections. The presence of radiologic finding of bronchiectasis should alert clinicians to explore other causes, including congenital defects, chronic inflammation, immune deficiencies, opportunistic infections, and assess for functional lung capacity, as multiple etiologies contribute to bronchiectasis, as was noted in our patient. We present a case of a middle-aged Hispanic male who was diagnosed with bronchiectasis in the setting of active Mycobacterium tuberculosis, common variable immunodeficiency, and cystic fibrosis carrier. A 44-year-old Hispanic male with history of SARS-CoV-2 infection presented with worsening cough and fatigue. He reported fever, night sweats, 50 pounds, unintentional weight loss, and yellowish sputum production. Chest CT showed diffuse bronchial dilation and thickening. Diffuse bronchiectasis, as shown in Figure 1, where bronchioles fail to taper distally. Multifocal cavitary lesions in bilateral upper lobes, as shown by Figure 2, and tree in bud nodularity, as pointed out by double head arrow in the bottom of the figure. Initial workup included quantiferon TB gold, which was indeterminate. However, acid-fast bacilli on smear and culture were positive in all the 3 specimens obtained. PCR further confirmed Mycobacterium tuberculosis complex. He was found to be immunodeficient with low IgG levels of 661 and IgM levels of 26. Genetic testing was positive for heterozygous cystic fibrosis D508 gene mutation. He was treated with quadruple therapy with rifampin, isoniazid, pyrazinamide, and ethambutol. Chest physiotherapy, duonebs, and bronchodilators to clear the airway secretion were also an important part of his management. He was referred to an immunologist for immunoglobulin therapy upon discharge. Bronchiectasis is a vicious cycle of airway damage, making it a conducive environment for chronic colonization of bacteria, causing an inflammatory response leading to further injury. The biggest diagnostic challenge of the case was to determine if bronchiectasis was due to an infectious cause or if it developed infection due to an underlying predisposition such as his immunodeficiency and being a cystic fibrosis carrier. His clinical symptoms were worrisome for tuberculosis. However, diffuse bronchial dilation in our patient was concerning for other concurrent pathologies which warranted further workup. Bronchiectasis is usually viewed as cystic fibrosis-induced versus non-cystic fibrosis-induced. Cystic fibrosis is an autosomal recessive disorder, and bronchiectasis is classically associated in cystic fibrosis patient. However, bronchiectasis has also been reported in patients having one gene mutation, as in our patient. Furthermore, TB and CVID are also documented causes of bronchiectasis. So treatment pharmacologically is challenging and depends on the etiology. However, non-pharmacological treatment such as chest physiotherapy geared towards mobilizing and eliminating mucosal secretion is used to manage all bronchiectasis. The rise in the incidence of bronchiectasis annually in the U.S. demands a pressing need to understand the etiology and characteristic features of the disease, as the effective treatment is directed towards the particular cause of bronchiectasis.